and welcome to the Road to Genome podcast. I'm your host, Helen Bethell, Genetic Counsellor and Workforce Development and Education Lead for the North Eastern Yorkshire Genomic Medicine Service, or GMS. Today, I'm delighted to be joined by Lydia Green, who is here to tell us about her work in the fascinating area of white matter disorders. Hi, Lydia.
Hi.
Hi, lovely for you to join us. So can we start then just by me asking you, what is your current job title?
So I wear two hats at the moment. I am a consultant paediatric neurologist here at Leeds, and I'm also a PhD fellow at the University of Leeds.
Fantastic. And can you tell us a little bit about what each of those mean?
Yeah, so in my day job, I'm a doctor of looking after babies and children with brain problems, so things like epilepsy, stroke. And my area of special interest is something called inherited white matter disorders or leukodystrophies. Now, they're exceedingly rare genetic conditions that start usually in childhood. Mm-hmm. There are some adult conditions and affect children in terms of their development, their communication, their motor skills. And part of my job at the moment is, yes, we have a local service, but I'm also joint lead for the national service in the north of the UK as well. Okay. And then on my academic side, what I'm doing is I'm doing a PhD looking at the genetics of leukodystrophies. So the genes that cause the problems, the mutations in the genes that cause the problems, and then understanding, firstly, can we diagnose them better? Can we diagnose them quicker? And eventually, do we understand them well enough to start thinking about how we treat them? Because at the moment, this is really a group of mostly untreatable conditions.
And do they happen at any age in childhood, or is there a particular age range where?
So there's, if you talk about conditions individually, there's probably well over 100 different genes that cause loads of individual conditions within that. And some of those have really characteristic phenotypes. So there's some that will come in the newborn period and you'll pick them up in the first few weeks of life. There's some that start as you get into school age and some that start at 7, 8, 9 and you tell me a story and I think you've got this problem. Then there are some, even within the same title or label of condition, that can present in newborn babies, in children, and then in 50-year-old adults. And they all look slightly different. So unfortunately, it's a really big group of very rare things that can present in lots of different ways, which makes them really tricky.
So when you say these are, the white matter disorders are rare, how rare is rare?
So if you think about epilepsy, people think not many children have epilepsy. Actually, probably every year, 600 people are diagnosed with epilepsy in the UK in terms of children. So that's actually quite a lot.
Yeah.
A very rare disease is less than 1 in 100,000 population. So it's tiny numbers. So things that you already think are rare, times that by 100,000, and then you're talking about our disorders.
I appreciate there's lots of different ways, but could you give us a kind of typical example of what kind of you might see in a patient?
Yeah, so I think one of our more common disorders is something called Alexander's disease. So there tend to be children that often have a little bit of developmental delay. So parents might have said, oh, they were just a bit behind with the milestones. They didn't talk quite as quickly as their other children in their class, but nothing big. And then in the first couple of years of life, they might notice the head's a bit bigger. They may start to have some behavioural problems, so they're just a bit more challenging. And often they get diagnosed with autism, actually. But then we find there's a problem with the brain that's causing all of those things. And then they can go on to develop seizures, movement problems, walking problems. And often over years, those things get trickier with time. So I might see them at 2 or 3 or 4 when a diagnosis is made. And actually, they don't look too different from the other 2 and 3 or 4-year-olds. But actually, the problems they have when they're 8 or 9 or 10 would be really different.
Yeah.
And many, not all, but many of these disorders are life-limiting. So they're things that might mean they don't reach adulthood or they don't reach adolescence, and that's a different challenge in itself.
Okay. And you mentioned the term white matter.
Yep.
Can you explain that a little bit more?
So when we look at our brain, we really talk about 2 different structures. So you have your grey matter, that's your thinking bit, the bit that makes the decisions. And then that has to pass the messages to your body. And it essentially does that through your nerves. But like an electrical wire, to pass those messages on, it needs good insulation. So wrapped around your nerves, you have your white matter. And that sort of keeps your nerves healthy, keeps them insulated, allows you to pass those messages well. So if your brain thinks, scratch your nose, you can pass that message down to your hand and you know how to scratch your nose. But if you've not got that electrical covering on, like your electrical wires, you just get a fizzle and a sizzle and that message doesn't get to where you want it to be. So that means you can't do the thinking and pass those messages on to make your body do the things you want it to do.
Yeah. That sounds an absolutely fascinating piece of science, doesn't it, and understanding that. So when you were a child then, was this what you aspired to be, either in your PhD role or in your medical role? Is it what you've always wanted to do?
Definitely not. I spent the majority of my childhood aspiring to either being an actress or a vet.
Wow.
One of those two things.
And have you pursued the actor line outside of work?
No, I did A-level acting, and probably was the most successful thing I did in my A-levels, because I have to admit I wasn't the best student. So no, up till then, but not since. And then in terms of veterinary, it turns out that you can't be a zoo vet. You have to look after hamsters most of the time, and that's decidedly less exciting. So I rapidly looked elsewhere for other things I could be doing with my skills.
Fantastic. So what took you then from your dreams of being an actor and a vet to now sitting in this position? What was your journey like?
So I almost say thankfully. So thankfully, I did not do as well as I expected in my A-levels. So having got offers for veterinary, I didn't get places, which made me reevaluate. But I think by that time, I'd already worked out that I probably didn't want to do that. Mm-hmm. And when you've done all right at school, yes, I didn't do great at my A-levels. You think about, well, what other careers are open to me? And I found a friend who did a clinical sciences course at Bradford. So it's essentially a transfer course. Mm-hmm. You do a foundation year, and the people that do top can interview to transfer to Leeds Medical School. Mm-hmm. So I sort of did the backdoor entry into medicine, and it's been the best thing I've done. I loved it. I love my job. I wouldn't do anything else.
That's fantastic to hear. That really is. And was although you kind of almost fell into medicine, is this something that kind of is medicine in your family? Do you come from, kind of any of the people that work within healthcare at all? Or?
So one of my cousin, who I'm very close to, is a doctor. She spent many a year, she's 7 years older than me, so had a bit of practice before I was getting around to it. Yeah. And spent many a time telling me this isn't what I should be doing with my time. Yeah. It's quite hard, the hours are long, and it's quite stressful. Yeah. And I think there was nothing else I wanted to do. So I think if it's the thing you want to do, even if it's hard, you just get on with it. And yeah, I'm really glad I've seen it through.
Do your family take much interest in your area of work, or?
Yeah, I think, I'm not sure everybody understands what I do. I think that's the first thing to say. Sometimes it's a bit tricky, even within your own family. I mean, my dad's a software engineer, my mum's a teacher, but she's taught with children with profound and multiple learning difficulties for a long time. Yeah. So she has some understanding of the types of children I might look after day to day. Yeah. And I think we've often sort of chatted and shared stories back and forth about rare diseases and challenging family life and all of those things. So yeah, I think they've always supported me and pushed me forwards to do more.
I wonder whether your mum's maybe got a good understanding of what value you can add to patients, in that, we know about how difficult that diagnostic journey can be for patients. And even though the types of conditions you're dealing with, it wouldn't be a welcome diagnosis, I don't think, for many families. Understanding it, I think maybe your mum from her area of work might maybe understand the value that brings. Yeah,
and I think it's part of to do that closure aspect of saying, actually, you've not just got a child with all these problems, but actually you can say what that is now. And that's easier, because I think what you find with our families is trying to explain a child with lots of challenges, but without a diagnosis can be really hard. And how do you translate that to something that school understand, and that your doctor understands over the end of a telephone, that your school trip understands? Whereas actually, if you can give things a label, it allows that first bit of sort of thought to go along with that. And I think that's a really big part of what we do in Leeds, is we're trying to transition or make it easier for patients to come to us and see us as an expert clinic, and then sort of filter that back through to their local team and their local environment. So it's not just about a medical letter from me to a GP to a local doctor, but actually the family having that documentation and description they can then take to their physio, their nursery, their community nurse specialist, those people that aren't going to see my letters but actually deal with the family on a day-to-day, week-to-week basis.
Yeah, absolutely. And often have gone through so many years of trying to work out what's going on, having to almost explain or justify themselves to people, that to give it, like you say, a label can be just of so much value to patients. Yeah. And so hopefully this podcast might actually help explain a little bit more about what you do to your family if they choose to take a listen. If you were to go back in time then to your younger self, who was about to become a world famous actress and vet at the same time, what bit of advice would you give to that younger person?
I think it's really tricky, and I think it's really hard, particularly now, to say, what do you want to be when you grow up? People often don't know. And what you want when you're, even me at 16, 17, 18, what I would have said then to what I am now is different. I came into medicine not wanting to do neurology, and partway through my career as a doctor, I went, actually, that's the thing I want to do more than anything.
Yeah.
So you change over time. So I think my biggest piece of advice is make yourself an all-rounder, have several strings to your bow and sample lots of different areas, because you never know what you're going to fall in love with. And you should love what you do, because work is a big part of life. And later on, particularly for people sort of in medical schools or on the career train, think about your CV. Every year, add one thing to your CV that you're proud of. So that's not a mandatory course that everybody else has done, but something extra. And it doesn't matter what field that's in. But if it turns out there's a job that you really want, you need to put yourself in a position to get that job. And unless you've got a bit of a well-rounded CV behind you, you're going to be making that harder. So even if you don't know what it is you want to do at the end of the day, make sure you're in a position to get the job you want when it comes to application time.
Yeah, what a great bit of advice. Really, really useful. You mentioned there about kind of that switch to neurology that you felt, quite strongly that you didn't want to be in it. And then obviously, what was it that changed that made you so driven towards neurology as a career path? Professor
John Livingston is the person that made that change in my life. So I was doing a neurology post as a ST2 doctor. So that's 3-4 years out of medical school, and just working on the paediatric neurosciences ward for 6 months as part of my training rotation. And I hadn't met John before. He wasn't on call at that point, but was still a working consultant in the trust. And we're in a meeting where I was chatting to one of the other consultants saying, I've got some research time. I've got an NIHR fellowship. I don't really know what to do with that. And he turned around and said, you want to do some research? Come with me. And that was the start of my neurology and white matter journey, really. And it's without that meeting, just in a Wednesday in an academic meeting, without that, I wouldn't be where I am now. And it's through all of him that he's exposed me to the world of rare disease, the world of white matter, the world of genomics, really, because that was the start of my genomic journey. So I owe him a lot. He's now retired and has built a lovely house in the north of Scotland. But he's here to hold my hand, just in case.
That sounds fantastic, yeah. And so you mentioned there genomics then. So was that the very first time you'd heard of genomics, or had you heard about it more in your training before then?
So I think as a medical training, you obviously talk about genetic disease, you learn about genetics, but I think probably the word genomics was probably from that. So I think that was 2016 when I sort of met John and started with the white matter MDT. And then we were probably writing up cases from 2017, and then you're talking about the genomic revolution. I think that's probably the first phrase or term I heard it with, where they're talking about how in the last 5 to 10 years genomics has not just come on, it's changed and revolutionized what we've done. And so I think probably 2017 in that context.
Yeah, and I think that kind of that time frame mimics with when I first heard the term genomics. So confession time here, I remember going on maternity leave and I came back and everybody was talking about genomics. And I was like, what's genomics? Why are we referring to genomics and not genetics? And I myself, as a genetic counsellor was confused by it. But that shift had just happened when I wasn't there. So within that 12-month period, there was just that shift in terminology. And, part of the work we've done in the last year has really shown that people struggle and even understanding that term. Once you say genetics, they have a much clearer understanding about what it is. But it was around that 2016, 2017 where that kind of change kind of happened. How many years then have you been in the field of kind of neurology and white matter? And how do you think things have changed in the time that you've been working in the field?
So I think probably from my first proper contact is sort of, we had the Leeds MDT, so multidisciplinary team that John led. And that was sort of a local in-house, his long-standing interest that he developed in his own time and through his clinical work, where we had meetings on a sort of every other month with geneticists, doctors, neurologists, neuroradiologists, and looked at our patients, had referrals from all around the world actually at that point in time, and looked at tricky cases. So I came in just as that was starting in 2016. I was still a trainee, rotating around my paediatric rotations in Yorkshire, so going through different services, but kept my ties in from that time within the service. And then through that time, I've continued my training, had a couple of babies, so a bit of mat leave, and then finally came back from my last mat leave in 2022 as a consultant, was a consultant just before, but came back to a consultant neurologist leading the service for Yorkshire. And John pushed back his retirement slightly to cover my maternity leave so that he could look after that position for me and I could come back at the head of it, really, and with the career that I've always wanted and the job ready for me and something that I've got great interest in. So
how is it being did you say a national lead for the service? How is it in that role?
extremely daunting. So there's nothing like coming in as a brand shiny new consultant saying, and here you go, there's 3 jobs in the country of which you'd like one of them, and take it away. So no, I think I've been extremely fortunate. I think there's 3 paediatric centres in the National Service. So we're north, so we're joint with Manchester. So there's a Leeds and Manchester team. We're the joint north of the UK centre. And it's a big responsibility. But I think John did the work to get it set up. He spent 13 years working with NHS England to get the highly specialised service developed. So through him, I've grown up in that. So although there are much more experienced clinicians doing the medicine, actually that setup of what he saw as the future vision for the service, that's the bit that I can bring. And the way that we interact with genetics and our genetic colleagues, not all of the clinicians have done it in that way. So I think some of the future advantages of the service are things that I've always grown up doing. So although it's daunting, and I'm definitely the youngest of us, no offence to my colleagues, but having that sort of training background from really the start of my training means that I've been able to come in, take it on. And I'm dealing with patients, and some of them have got conditions I've never seen before. But for many neurologists, even 20 years into their career, they may never have seen those before as well. And the more you do, the more experience you get. I've now got collections of family with disorders that other people will never have seen. And I'm accumulating them week by week. We've actually just had a flurry where I've had about 9 diagnoses in about 7-8 weeks, which is just phenomenal. So I'm seeing them back. Yeah. And you just build on that. So I now build my experience, build my confidence, know people all around, well, the UK, but actually internationally, we've got those connections, and you just build it.
Is there so you mentioned a flurry of new diagnoses. Is there a connecting factor with why those have come? Is WGS a part of that, or is it just part of chance that they've all come together at a similar time?
So I think we talked about how things have changed in my short time doing this. So I think part of it is going from talking about what's the gene to how do we manage it and treat it. But with that has come in whole genome sequencing and the service. So I think the UK was the first country that took whole genome to be their standard of care for genetic testing right at the off. And that's really been amazing. So we were doing an in-house exome before that. So that meant we were getting the patient's DNA, looking at that, and we had an amazing clinical scientist who was stripping it back, looking in different ways that normal testing wouldn't. So actually we found a lot of diagnoses here with our in-house testing. But patients had to come to us. We had to get their samples to do it. And we could look at the exome, so coding bits of your DNA, but not everything. Now we've got all the data from the whole genome, and usually not just from the child, but their parents. So what you can do with that data is just so much bigger. Now, what's given me so many diagnoses recently? So yes, almost all of those are through whole genome, but I think also part of the whole genome service is the rapid sequencing that Exeter's doing. So that allows me to, instead of waiting a while, let's say for whole genome results in Yorkshire, there is a pathway for certain patients to now get rapid genetic results within 2 to 3 weeks.
Wow.
And one of the indications for that test is patients that have got regression. So they've lost skills. So they were better 3 months ago than they are now, and many of my patients will fit into that
typical.
box. So I'm going to see a lot of patients that come being well and then regress and lose those skills, so we can access that testing for a lot of our patients, and actually within 2 weeks I can give them an answer, whereas in the past
what an incredible achievement within science introducing that. And it's brilliant to hear where there can be difficulties in turnaround times for WGS, and my personal feelings is that will come in time. This is a new service and isn't without its difficulties, but to hear of an area of medicine where it has been successfully embedded and is having such amazing impact to those 9 families that have got that diagnosis back within those 2-3 weeks is just incredible. So it's lovely to hear a success of where WGS is being so impactful.
And I think the Exeter service is that's the model.
Gold
that
standard,
is where we will go. And I think, unfortunately, like you said, WGS is new. I don't think it all works perfectly at the moment. I think for rare disease, without that agnostic, so the ability to look at it in a tailored way, isn't perfect. So there are limitations, but it will come with time. And it's just the money, the staffing, the manpower to get it going. But we're leading the way on doing it. It's just step by step.
So thinking about your work then, what's been the most challenging part for you?
So I think 2 things. So I think in terms of genomics, so I think the loss of that exome we've just talked about a little bit. So we could do the test we offered our patients, not the turnaround time, but the test we offered our patients was really good.
Mm-hmm.
And it probably was better than some of the standard whole genome that we offer now without that urgent extra test. So that has been tricky, saying that actually what I did a few years ago, I can't do now. And so that there's been a slight backward step in some of that. But then watching the other side of the service grow and develop and seeing how what I did for a small group of patients is now lots of people are able to do something for all the patients.
Yeah.
You have to just see the benefits of that in the long run, even though it's been a tricky for a year or two here. Actually, it will grow and it will get better and it will improve. And overall, that will make huge benefit for our families.
Yeah. So on the flip side, what's the most rewarding part of your job, would you say?
So I think since the national service started, we've been really fortunate. So we've recruited a new coordinator, a new nurse specialist. And so I've taken it from a clinic I inherited from John Livingston with a small number of patients. I've now got a huge clinic in Leeds. And part of that is a really dedicated white matter team. I've got a nurse specialist that has been in post for a couple of years. She's contacting families, she's supporting families. If people need something, they just ring her and she's able to get back to them. And our coordinator that between me, Manchester, genetic labs all around the country, referrals, she's supervising and organising all of that. And actually we've got a team of young professionals that it's not just a job, this is our career. And that's not just me, that's them as well. So we've grown something. And through that, we now have a really supportive, responsive service for our families. We can get them in quickly. We can speak to them with all the staff that we need. I've got the information that they need at diagnosis. And we've had really positive feedback. So can I always tell them that positive news? Absolutely not. I spend a lot of my time telling families the worst news that they've ever had in their lives, and I speak to them at their lowest. But I can do that in a way that is informed, experienced and supported. And we send them away, and next week they've got someone picking them up. They've got next week they've got someone on a home visit, a telephone call, talking to families, visiting their schools. We can do that because we've worked really hard to do that, and it makes a massive difference.
It sounds an incredible service. It really does. Do you mind me asking then, for you personally, how do you cope with that regular delivering of such devastating news?
I think it's something I've thought about a lot over my career, and particularly when I speak, people say, oh my God, you must do the worst job in the world. And I think part of it is focusing on it's my job and it's my role, and that's not my grief, that's that family's grief. And I have to be able to distance myself from that. My role in making their lives better is being professional, accessible, reliable, supportive, and not taking that all on myself. And if I can achieve that, yes, it's sad, but it makes a huge impact and a huge difference. And that's the bit you have to focus on. So I can separate me from my role in making their lives that little bit better.
Yeah. And I guess it goes back to what we talked about before with, kind of what your mum sees and what is that value of a diagnosis. As you say, it can be the hardest diagnosis to give, but it sounds like you are really rooted in understanding the value of that and what that is going to enable the family to access in terms of the support that they're going to need. So your service sounds incredibly well set up in terms of supporting patients through that journey.
Yeah, and I think there's so much more we're going to be doing. We've got big plans to make things even better going forward. It's all a slow process, as with anything in the NHS, but you're right, it's about these families. Before I had this discussion, they weren't not worried. They weren't already worrying about the worst things ever. But what I've been able to do is give them closure, give them accurate information, talk about what the future might mean, stop admissions for tests and scans and coming to hospital all the time. So actually draw a line under that and say, this is where we are, this is what your future will look like, and this is how I'm going to support you. And that is just overwhelming for families. Is it happy news? No. But does it have some positives? Absolutely. And I think that's for the families, but also for us as a healthcare system. Everything that we do is costly. Everything that we do is time. And if we can reduce the burden on families and reduce the burden on the healthcare system whilst providing better support, I mean, that's a win-win for all, isn't it?
Yeah. I think what massively comes across, Lydia, is your passion for supporting the patient. And it's just absolutely admirable, kind of from across the team. It really is. Yeah,
I mean, everybody's job's different, and I think sometimes my husband curses me the fact that I love my job so much, but it's part of what we do, and I can't I can't take some of the badness away, but you can make it better.
Yeah. Obviously, you're really passionate about your work. Can you pick out maybe one case that has maybe stayed with you?
Yeah, so I think we deal with a lot of rare diseases. I've got some families where they're the only family in the world that's got something, which is great. But I think probably my most interesting or pivotal case that really sort of pulled me in was probably again around that sort of 2017 time. We had a family come to John at the time leading the service saying, I'm pregnant. Her sisters had a baby that's passed away with something awful in the past. Can you tell me that my child's not going to have that? Now, we'd reviewed the child's scans previously. This child themselves was deceased now, and we didn't have a diagnosis. That child we had a tiny amount of DNA for, but not enough to test. So what we did some retrospective testing. So we actually tested the mum and looked at all of her genes to try and find a spelling mistake in a gene that would match the scan of the baby. And we found a novel spelling mistake in something called IBA57. And this is a gene that essentially helps your mitochondria, so the batteries of your cells, keep going, keep making energy, keep your body working. And there was a spelling mistake that eventually meant that gene wasn't working properly. So therefore your cells aren't going to make energy properly. And we looked and we went, that's interesting, because there's lots of problems with cell energy batteries, and the scans look exactly like this child's scan did. So we think that spelling mistake in that gene could really fit the scan changes we see in this baby. So we had a tiny bit of DNA left. So then we tested. So we did a single gene test on the DNA for that child. So that's all we had left. There was nothing else to do. And yeah, indeed, we found where mum had one abnormal copy of a gene, so she wasn't affected. This child had two abnormal copies of this gene. This was going to be his diagnosis. So yes, we diagnosed him. Yes, we allowed to then have screening for the pregnant aunt with the baby, so we could screen her child. But also we went back in our service and went, so who else have we got scans with that look a bit like that? And diagnosed another two there, and subsequently a couple more. I had a new diagnosis. One of my 9 recent was the same gene. And this was just a brand new gene.
Wow, just like that.
Just like that. And it was from one pregnant woman who isn't a patient. We then found all of these other ones. And even now, we're finding more and more of them. And it's just that story of how you piece together little bits of a puzzle to make a bigger picture for more than one patient in this case.
Yeah. That one test in the mum of the deceased child actually opened the door to answers amongst the family and the wider family, and that's incredible.
The power of genomics, shall we say?
Yeah, absolutely. Yeah. From a charity sector, then, is there many charities that support the families and the work that you're doing?
So we've been really, really fortunate, and we've worked alongside Alex TLC for a really long time. So there's Alex, the Leukodystrophy charity. Now they are previous life, ALD life. So the founders of this are both mums who had boys diagnosed with adrenal leukodystrophy and have gone through that personal patient family journey themselves. And not many years ago now, they decided that, or they realised that they were supporting families with ALD, one of the more common leukodystrophies, really well. But there were loads of rare leukodystrophy families with no support or with very, very minimal support, and they wanted to improve that across the country. So now they support all different leukodystrophies, whatever your diagnosis, and they've worked not only with us in the service now, so they have honorary contracts, they can come to clinic, they can meet our families, but they've also helped in the service design with Dr Livingston over those decade or so. We do joint events, we do joint family weekends. So I'm going in October where we have a scientific day on the Friday, and then Saturday, Sunday, families with leukodystrophy, adults, children, everybody comes, and we have international speakers from all over the world. So yes, there are other groups, but we work really, really closely with Alex TLC, and I think that only benefits us as clinicians in a service, but also the families that we deal with. Yeah,
and what incredible support for that community that event sounds.
Yeah, it's another way of learning about our patients in a way that they might not present to their doctor. So let's hear it from a different side. And then we feed back what's up and coming, what's new, what's going on. And families want to know that stuff. And it's a way of us reaching out in both directions.
Yeah, fantastic. Over your career then, Lydia, what would you say is the most important genomic development that's happened?
So I think in the UK, and I think we've probably talked about this already, is sort of that use of whole genome coming as a standard of care for everybody. So yes, we did a test for some patients that was a bit smaller than that, but actually now you can walk in with a neurological problem or a kidney problem or a heart problem, and you can access genetic testing on a much bigger, broader scale than was ever available before. And at the first hit, so we're no longer... So when I started doing neurology, you did your first round of tests, waited 4 to 6 weeks for the results to come back. If they were negative, you did next round of tests, you wait 4 to 6 weeks, wait for them to come back. And eventually you did some genetic testing, often a single gene to start with, wait for that to come back, a couple more genes. And now you come in and say, yes, I might send some of the first round tests, but actually if I can send a quick genetic test and have a result in 2 weeks, we might not need to do all of those blood tests, do all of those skin biopsies, do all of those muscle biopsies, and you never needed the invasive testing. So I think that sort of standard of care, access your whole genome first up, is probably the biggest change in my career thus far in the UK. Now, outside of the UK, there are centres that have moved on from what is the gene, what is the genetic diagnosis, to actually how can we treat it? And I think in my lifetime and in my career thus far in 8 years, we've already seen treatments and trials coming through for conditions I never thought there would be. And in my lifetime, I have absolutely no doubt that some of our rare disorders will have gene therapies underway for those patients. So I think it's what's happened already has been big, and what's going to happen in the next 20, 25 years is going to be huge.
So can you mentioned that gene therapy, can you just explain a little bit about that, and kind of particularly in white matter disorders, how that might be used to treat a patient?
Yeah, so at the moment we have we're talking about a problem with the way that our white matter works. Now that's not always the way the white matter itself is built, but just some way it's maintained. There's loads of different aspects of white matter maintenance, care, production that can be involved in those pathways. Now, sometimes we're built with a problem where you've never made any white matter to start with. I probably can't build that back in. But there's a lot of children that actually had good white matter. It was working, it was growing, they were well, but because of a gene defect or a gene mutation, part of that pathway's gone wrong and damage starts to occur. Now, what gene therapy does is you identify part of the pathway of the problem and then try and block that.
Okay.
So for those patients where actually they had good functioning white matter
There's
up
just
to a
something
point,
else interfering with it.
can we block that badness and allow them to continue? Or at least if you can't put things back, can you stop the progression if you pick it up early enough? Now, some of these things are already happening. So for a long time, we've had treatments for something called adrenal leukodystrophy. That's probably one of the most common white matter disorders. That tends to be managed by the metabolic team, actually, and you can have a bone marrow transplant for that. What the really sad thing about that is, once you've presented with symptoms, you're probably not treatable. So actually my patients that I get first, I probably can't treat them, because by the time I can see the symptoms on the outside, the damage to the brain on the inside is too advanced. But what we then tend to do is screen family members. So through that process, I've then picked up family members that are affected, carrying the gene, but not yet showing symptoms. So then I can treat those before they get problems. MLD, metachromatic leukodystrophy, there's now a treatment that's being pioneered. Manchester are the lead centre for that. And again, that's looking at blocking the problematic gene mutation to allow them to not progress to that state of damage. But you have to be early enough in the disease course for it to be beneficial.
Yeah. Tragic in the example you gave, that those children that are admitted showing symptoms are too late for treatment, but incredible that those younger siblings and wider family have got access to that. What do you think is the most exciting thing that's coming down the tracks?
I think it's this possibility and potential for targetable, treatable therapies for these disorders. So at the moment, for the majority of my patients, treatment symptomatic, I'm saying I can't make this better. I probably can't even slow this down, but I can manage the symptoms that you've got. I can prioritise quality of life. I can treat your painful tone. I can treat your sleepless nights, but I can't stop the process. In future, and I think within my lifetime, we're going to be able to say, this is your diagnosis and this is the personalised therapy that I can provide you for that. I'm not sure that will reverse problems in reality. For some, if we catch them early enough, I hope it will. There will be cures if you're not symptomatic. But even for those patients that are symptomatic, I'm hoping we're going to be able to say, and this is your treatment that stops this getting worse. And in the early days, that could make a massive difference to them and their families.
Which is just an absolutely incredible situation to be able to treat some of these devastating disease. So thinking now then about your research role then, Lydia. So when or where was it that your interest was sparked in research?
So very early on in my medical career, so really before neurology, I saw an advertisement for an NIHR academic clinical fellowship. So that just meant some money to do a little bit of research alongside your training. So you'd got little blocks for a 3-year period. Now that came with a really broad headline and was probably entitled as paediatric education. But then I did my neurology job and realised that actually I wanted to do neurology and could use that time and that money to try and develop a neurology project. So through that, we talked about the MDT and all of those things, some papers that came out of that, setting up projects. And from there onwards, we've realised there's bigger projects to be done. And I've developed that into essentially a PhD fellowship. And at the moment, I'm looking lots of different aspects. So the incidence and prevalence of white matter disorders in the UK, nobody actually knows the answer to that question. So we've had a national surveillance study going on. We're then looking at the genetics and the side of it and how we detect rare diseases. So we've talked a lot about whole genome today, but actually whole genome at the moment is looking for known mutations in known genes. It's not looking for new stuff. We're not going to pick up new stuff. And unfortunately, when you're dealing with children with rare disease, a lot of what you're looking for is novel or new. So current testing that's negative, so you have a negative whole genome, that's not necessarily a negative answer in terms of a genetic diagnosis. It just means it's one we've not found yet. So what we're doing through my PhD is looking at how can we manipulate that whole genome data. So we've got all your genetic information. How can we make that work in a better way to pick up rare diseases? At the moment, a lot of this testing is done through pipelines. So we get all the information in, the computer runs a pipeline and pulls the genetic information out for a scientist to then look at. How can we help those pipelines run better for rare diseases, for rare genetic disorders? And how can we then bring that to the service more widely? For example, there's something called long-range sequencing that is the big thing coming in genomic medicine. And we're just starting to do a bit of a trial alongside that in Leeds to see, is that something we can do and roll out? Yes, they have to have NHS whole genome first, but when that's negative, what are the next steps? And we're still getting a negative hit for probably 20-30% of patients, which if you think it's small numbers individually, but for those families, that's a really big deal. So what's the next step of that testing? How can we close that diagnostic gap? And that's really the first steps to then talking about, and then how can we treat them? Because if we're not picking them up, we can't treat them. So really that's what a lot of my PhD is about. It's understanding the genetics, making the tests work better and trying us to get to a diagnosis for more patients more quickly.
And how's it going? Are you getting close to answering some of those questions?
So I'm doing a part-time PhD, which as you can imagine, around full-time clinical work and 2 small children is a bit of a logistical nightmare. So what happens at the moment is I have 10 academic weeks a year where I do blocks of work. It is a challenge, and we've got a few projects on the go. We've had an example of a project that we're working on was where we had the first family that Dr Livingston had with a gene mutation identified years and years ago, probably around the 2016 mark actually. And since then we've set up an international group, and I've now got 18 patients, maybe more, 20 patients from 13-14 families, and we're about to publish that with a massive international cohort. This gene's never been described in human disease before, so there are massive positives to that. The networking, the way that we run the service is really good. I think the logistics of it are challenging. Does it make me better at my clinical job? 100%. Does it help me from a knowledge perspective? 100%. And actually at the end of my PhD, are we going to have something that I've made in a research setting that works for our NHS patients? Yeah, I'm fairly confident we are actually. So we are making progress. There's a lot of head banging, I will admit, but my supervisor is extremely tolerant of my inability to focus on a task for more than 2 weeks at a time. But I've been really fortunate. James is supervising me in a way that I think a lot of other PhD students wouldn't have the benefit of, but we're balancing a clinical job with a research life for the benefit of the future service, and I'm sure it will get there.
It sounds like the clinical role, because you are, breaking ground and discovering so many new diagnoses as you're going along. It sounds like those boundaries between clinical and research are very blurred anyway.
Yeah, I think so. I think it's the fact that again, going back to our genomic service. So at the moment, if we do an R14, so that's the rapid Exeter test, if you do those things, unless they think this gene mutation is causative, they don't even tell you about it. So there's lots of things that are found that probably mean nothing for your patient.
Yeah.
But unfortunately, in rare disease, it might mean something for your patient and we don't know yet. So what I've learned through my genetics experience and my PhD is how to interface with the genetics lab and the service in the NHS. And so we have so much back and forth. And through that, there's things that we would never have been told about that we then go, that's the diagnosis. And we know that because of X, Y, and Z. Yeah. And it's that back and forth. So yes, I think you can't do either role in isolation. I think being in the lab, you couldn't understand the clinical relevance of this and the way that you have to work in an NHS system to make these things move forwards. But equally, without my genetics knowledge, I couldn't make the clinical service work as well as it does now. And so those two things come hand in hand. And that's why it's going to be successful, I think, at the end of the day, because we have both parts moving together. Yeah.
And I guess it sounds like you're the conduit between those two things. So kind of having a foot in the camp of those, really understanding the molecular changes that are happening within the disease and bringing your clinical expertise into that. Sounds like an incredible role to be sat between those two elements.
Yeah, I still kick myself every day at how fortunate I've been in the way that my career has panned out. So I just happened to meet someone with an interest that I've ended up developing. He's happened to be developing a service that's got a place for me. And then he's pushed me to do research. Now, I did apply for a full-time PhD in the first instance, which I was shortlisted for but didn't get. And actually, I'm really glad I didn't get that because I'm not sure I'd want to be a full-time 3 years out of training researcher. I love my clinical job. And because I wasn't on that full-time role, when John's been at the point of retiring and the job I want is vacant, I'm ready to take it on. And yes, I'd have to do some balancing now, but I think it probably makes me better in both fields.
Yes.
Being able to do that. And I'm not sure many people would be able to do it the way I've done. I'm doing it slightly unusually, but it works. And that's been, I think I've been really fortunate all the way along that those stepping stones have just happened to align. I don't think that's anything I've done. They've just happened to fall into place, but it works.
Yeah. You mentioned about kind of international collaboration. So obviously with these being so rare, there's not enough examples within one country. So is there a lot of that international collaboration?
Yeah, so I think if you look internationally, there's probably 2 or 3 centres, and I'm not going to mention lots of names because otherwise I'll have missed someone, that are the white matter gurus of Europe and then wider in America as well. During my clinical fellowship, I had the opportunity to go and work in Amsterdam for a month with Nicole Wolff and Maya van den App, who are the goddesses or the queens of white matter disorders, and previously where we've taken all our challenging cases to. And I think just seeing how they do it. So in the Netherlands, their system is many medical students or doctors will come and do a PhD as part of their end of medical school training. So you finish medical school, then you do your PhD, then you sort of come into medical training. So that integration between clinical work, research is blurred all the way along for them. And whereas I was coming from somewhere where you're a doctor, and not many doctors do research, and how do you fit that in? I've seen how it can work. And the advances they're making, a lot of what we're talking about now is old hat. They're 10 strides ahead of us. And it's because they've just integrated research with clinical care for such a long time. And I just think that's something to aspire to. Is research for everybody? Absolutely not. Is full-time research something you should be doing? I'm not sure. It wouldn't even be for me. But I think you need to have some integration and some understanding of both sides of that linked coin to be able to drive services forwards wherever you work.
From your research, have you got questions still, or has it generated more questions for you?
Oh, I think it's always generating questions. I think that's how most good research projects work. I think day to day in work, there are challenges that you can't surpass in an NHS environment. Some things work the way that they work, and they have the benefit in a research setting to try and fiddle the system and find a different path. And that's really exciting. Sometimes it shows you things that work better, and sometimes it shows you that there is a dead end in the system and you can fight it, but it's better to accept it and move on. I think for us, the plan I went in with of working out how to make this run better, I'm not sure that's the best route anymore, and that's okay. And now we're working out, is there a better route to get a better diagnostic test? And I think we're just testing the waters there in a minute. So yeah, there's loads more to learn and loads more to develop, but it's about having the time to do it and thinking it through. It's changing all the time, but yes, always more questions, unfortunately, but keeps you on your toes.
So as a final question then, bringing this all together, where are you now with the service?
So I think at the moment we have a really good service for patients with white matter disorders. So if you're out there, patient, clinician, and you want some more information, just come find us. We're the IWMD service for the north of England, and we can offer patients clinical review if they need it. I can meet families if that's desired, but actually we can just discuss cases. You can live in the far reaches of Scotland. You don't need to travel and see me, but I can discuss you an MDT, liaise with your local clinician and give you advice on your diagnosis, your future investigation, your prognosis, your care. And our nurse specialist, wherever you are in the north of England, can help you liaise between medical care and your life and help you put that into place. Now we're just starting and it's growing. We're doing our first White Matter family picnic. I'm doing some fundraising and running lots of circles around Temple Newsome. And that's to raise awareness of what we do, because I think we're making things better for our families. That's the feedback we've had. And I'd just like to spread that to wider groups. At the moment, a lot of our patients are relatively close by. The message is starting to filter through, but it needs to filter through much more widely because we can make an impact, and that is huge for families.
Yeah. Well, what an incredible offer, and it's been incredible to talk to you, Lydia. Thanks so much.
No, thank you for having me, and sorry for jabbering away.
Not at all. And thanks to you for listening. If you'd like to learn more about some of the topics that we've discussed in this episode, then you can find the relevant links on our website, www.ney-genomics.org.uk/podcast.